Good afternoon and welcome everyone. My name is Nicole Sadler and I'm the Head of Policy and Practice at Phoenix Australia Centre for Post-Traumatic Mental Health. Phoenix Australia is a not-for-profit organisation and for over 25 years we've been dedicated to reducing the impact of trauma and post-traumatic mental health problems in individuals, work groups and the community. Thank you for joining us today to discuss identifying and managing trauma within the aged care sector. I'd like to start our session today with an acknowledgement of country. I acknowledge the traditional owners of the land where I'm situated today, the Ngunnawal people, and those are the lands where each of you is situated. We acknowledge the lands on which we meet are places of age-old ceremonies, of celebration, initiation and renewal, and that the local Aboriginal peoples have had and continue to have a unique role in the life of these lands. Let me now briefly outline how today's webinar will run. Anne-Laure Quinault will give you a brief overview of the work Phoenix Australia is doing as part of the Australian Government's Grief and Trauma Response Package, of which this webinar is one part. Jane Nursey will then outline what we mean by trauma, how trauma is experienced at different stages of life, the impacts of trauma, and what benefits trauma-informed care can bring in aged care settings. Dr. Richard Bonwick will then discuss trauma in aged care settings and the interactions between trauma and dementia. Following these short presentations, all the speakers will come back together for a panel discussion on the impacts of trauma in aged care and how we may apply the principles of trauma-informed care. There'll be an opportunity for you to ask questions of the panel and vote on other questions submitted by attendees. Just before we start the presentations, I'd like to cover some basic housekeeping to ensure you have the best experience today. As you can see on your screen, there are two boxes below the webinar stream. One is a chat box where we encourage you to comment and chat to each other by entering your name and clicking Join Chat. The other is a Q&A and polling feature. We encourage you to ask questions, but also to vote for questions you'd like our panel to respond to. You can do this by typing a question and either entering your name or leaving it blank if you'd rather remain anonymous. Should you see a question you want to vote for, hit the like button to help ensure we answer it today. There'll also be a poll towards the end of the event. Please complete this by navigating to the Polls tab within the Q&A. I'll let you know when the poll is launched. Should you experience any technical issues, please navigate to the chat box at the bottom right of the page and our team will be able to assist you immediately. Now a quick background on who our speakers are today. Anne-Laure Quinault is Director, Policy and Service Development at Phoenix Australia. She's a psychologist and leads our work to promote best practice and service improvement for organisations that support people exposed to trauma. She has extensive experience in the field of complex trauma and interpersonal violence. Jane Nursey is Director, Clinical Services at Phoenix Australia. She's a clinical neuropsychologist with almost 30 years' experience in the field of post-traumatic mental health, including as a clinician and manager and director of programs and services in the public hospital, acute and mental health sectors across the lifespan. She's also worked in alcohol and drug, traumatic brain injury, aged care and developmental disability sectors. Finally, Richard Bonwick is a psychiatrist who specialises in old age psychiatry and treating ageing war veterans. He has spoken and written nationally and internationally on a variety of topics in old age psychiatry. He's an expert clinical advisor to Phoenix Australia and an honorary clinical senior lecturer at the University of Melbourne. Anne-Laure, welcome. Would you please start us off with an overview of the work Phoenix Australia is doing within the Australian Government?
Thank you, Nicole. Hi, everyone. So, as Nicole said, this webinar is part of a package that is funded by the Department of Health. And this package is going to be delivered by three organizations. So us, Phoenix Australia, Dementia Support Australia, and the Australian Centre for Grief and Bereavement. Our package will include resources to support trauma-informed practice across aged care services. So there'll be three components. One is resources for organizations to help them implement trauma-informed care, should they choose to do it, resources for staff, and then resources for residents and families and carers. In terms of the resources for organizations, we have a number of things that we can offer organization. One will be a trauma-informed framework that will be adapted for the aged care sector, and will consult extensively to develop a framework that really works across services. We'll also then develop a self-assessment tool for agencies that wish to introduce trauma-informed care. It is designed to help them assess their readiness for implementing trauma-informed care and to assess the needs of their staff and their policies. We'll also have resources for staff, and that will include brief guides to trauma-informed care for aged care. And that will be for workers and their managers. We'll also have trauma awareness videos. We'll have plain language information that will be presented in a number of ways. So some of them might be videos and animations, and others handouts. We'll also have a series of webinars like this one. We'll also have online training to upskill staff that will be offered in brief modules, because we know that people in the aged care sector are really time poor, and resources to support employee well-being. And finally, we'll have information for the residents, their families, and their carers. And that will be educational videos and plain language information that's printed and available throughout aged care services. And now I'm going to hand over to Jen and Richard, who will be talking to us, as Nicole mentioned, about trauma and its impact, particularly in aged care setting, and the interaction between trauma and dementia and trauma-informed care.
Thanks very much, Anne-Laure, and welcome everyone. It's great to be here. So I think it's important to start off a conversation about trauma by really defining what we mean by a traumatic event. It's important to recognise that traumatic events aren't just our everyday stresses or even significant stresses that we might encounter on a daily basis. What we're talking about really when we talk about trauma is an event that is extraordinary, that really challenges our coping skills and puts us in a spot where we're really feeling overwhelmed and quite distressed by it. It will often involve a threat to ourselves or to others. It most commonly comes on suddenly or is unexpected. We are either personally involved directly, or we might be witnessing it happen to somebody else, or it might be that we become aware of it happening to someone who's very close to us, a loved one, a child, a parent, a close friend. A traumatic event usually induces intense feelings that include fear, a sense of helplessness and powerlessness, and really, as I say, overwhelm our normal coping abilities. It includes a whole range of different events, and it's impossible to really sort of go through them all here, but certainly things like assault and abuse. So being attacked by someone, physically, sexually, emotionally abused, motor vehicle accidents, workplace accidents, things like natural disasters, war, traumatic losses where we might lose someone close to us through some traumatic means. Even pandemics at some level might fall into a into a category of trauma, particularly if it involves significant loss. It's very common for us to be experiencing trauma. So at least 75% of Australians are going to experience a traumatic event in their lifetime, and 68% of us by the age of 16 will have had exposure to a traumatic event. There's a range, as I said, of categories of traumatic events. Really common ones that you are likely to see for people coming into the aged care sector are certainly domestic violence. We unfortunately have high levels of domestic violence in Australia. 1 in 4 women, 1 in 6 men are likely to have experienced some sort of emotional abuse. And, 17% of women are likely to experience some level of physical violence as well. The other thing for us to be really aware of in the aged care sector is elder abuse, and I'm sure that all of you are very familiar with. Unfortunately, again, it's not an uncommon experience, and we can see it impacting elderly people in many different ways. And the abuse might take many forms. It might be financial, it might be physical, sexual, emotional. Regardless, it often has devastating impacts, and can often lead to that point where really this elder person is losing complete independence and really having their life shattered by that event with significant consequences. It's important to recognise that trauma can happen at any point throughout our life. Even embryos in utero, where mothers are experiencing significant trauma, are going to, at some level, experience an impact from that. And certainly impact at end of life, or traumatic experiences at the end of life aren't uncommon. Some groups are much more vulnerable and at risk for higher levels of exposure. And if we think about groups like refugees, Indigenous families, members of the LGBTQI community who often get discriminated against and potentially attacked, certainly people with disability, and people who work in high-risk professions. So our Defence Force, our emergency service personnel, even people like train drivers and others who might work in professions where there is a high risk that they will come across a traumatic incident as part of their work. The more traumatic experience that somebody has, the higher the risk they have of developing a mental health disorder at some point in their life following that event. It doesn't need to be immediately after the event. It might be some years down the track where that mental health disorders, but can be linked back to the traumatic event. We do know that traumatic events experienced in childhood can have a very long-lasting impact. Both on the development of the child in terms of it can change the trajectory of neurodevelopment, brain development. It can certainly arrest and change emotional, social, and cognitive developmental pathways, which really then have long-term implications in terms of education, occupation, perhaps financial independence, and a whole range of other things. People who develop mental health disorders as a result of trauma often do experience that symptoms of that mental health disorder off and on throughout their lives. So it's not something that's there for a brief period and disappears. For a percentage of people who seek help early, they might get resolution of that disorder and actually be quite well. But for others, it's often a relapsing remitting course, if you like, of the disorder going up and down over their life. And certainly once we come into older age, the cumulative impacts of loss and grief arising from a lifetime exposure to trauma, but also the losses associated with the aging process itself, is loss of physical abilities, loss of cognitive abilities, loss of independence, socially, emotionally, can all have an impact. The impacts of trauma, and I'm not going to go into them too much here, but the impacts can vary from individual to individual. Essentially, any reaction to a traumatic event we consider to be a normal reaction because everyone will have their own response. But we know that we do commonly see in the immediate aftermath of traumatic events fairly significant changes in people's experience of intense emotional reactions, often changes in their physical reactions, significant change in behaviour, often either isolating themselves or be taking more risks or whatever, and an impact on their cognition, particularly their ability to concentrate, to focus, to think clearly. And more importantly, perhaps, impacts on their ability to function in their day-to-day life. And Dr. Bomwick will go into those a bit more in depth in a minute. The other thing that we commonly see as impacts of trauma are changes in our relationships with others. As soon as we're experiencing significant emotional distress or any of those changes in behavioural, physical difficulties, then it is going to impact on the people around us and the people that we interact with. And a common reaction for people who have been traumatised is to isolate themselves, withdraw, not engage as well. And also, anger becomes a really prominent emotion as a way of defending themselves. So, that, as you can see, can have a significant impact on their relationships generally. And it's one of the reasons why we do see a significant increase in domestic violence after trauma, and particularly after natural disasters or in war situations. The levels of domestic violence increase significantly. One of the most important factors in guarding against that is social connectedness. We know that social isolation is one of the biggest risk factors for developing a mental health disorder, regardless of whether trauma is the cause of that, in fact. It's certainly a big contributor, but certainly for people who are traumatised, social isolation is a huge risk factor in terms of impeding recovery. It's also one of the biggest predictors. If people have good social supports around them, then it's the best predictor we have of recovering from the impacts of that trauma. Some of the longer term impacts that we can see, I've gone through some of these, so I won't labour it, but I guess some of the interesting ones here are perhaps chronic feelings of shame, guilt, grief, mistrust, and anger. Trauma shatters our belief, our normal beliefs, our normal assumptions about the world. We lose trust in ourselves and our ability to cope. We lose trust in others and their intentions and what they can do to support us. We lose trust in the predictability of life and the predictability of the world. And often then carries with it there's often significant loss associated with trauma, so there's ongoing grief, and there's often shame and guilt about the experience of the feelings that go with our reactions to trauma. Another one is I guess I've mentioned the change beliefs and the view of the world. But all of that over a period of time can certainly lead to a loss of identity. The person no longer feels like the person they were before the trauma. They're no longer able to function at the same level, do the same things, or they're perceived by others as being difficult. And so for many, they carry that with them, but it's hidden. It's not something that is expressed outwardly, but it does impact their behaviour and how they interact with others. There's also a range of mental health disorders that can arise from trauma. A common are anxiety and depression. Substance abuse is also common after trauma. But perhaps one of the important ones is post-traumatic stress disorder. And one of the things that's unique to post-traumatic stress disorder is that it carries with it this re-experiencing of the trauma off and on throughout their lives. So, and that can be really intense recall of that trauma, like they're reliving it. Something that they see, something they hear, something that they smell, re-triggers all of those intense emotional responses, and they're back there reliving the event. Or it might happen in dreams and nightmares. What goes along with that is strong avoidance behaviours. Avoiding engaging with others, avoiding going out, avoiding doing normal routines, anything that's going to put them at risk of precipitating one of those re-experiencing phenomena is sort of cut off. And so people's lives can be very narrowed down, very restricted for long periods of time, particularly if it's gone untreated. In the elderly, the other sort of symptoms or presentations of trauma certainly change in cognitions and beliefs, and often a lot of hyperarousal and reactivity. In the elderly people, often what we see is less of that re-experiencing phenomena and usually more presentation of somatic complaints. So reports of pain, chest pain, physical pain, maybe fatigue, loss of appetite, those sorts of things become much more prominent in elderly people, and they'll present with that to the doctor rather than feeling low or anxious. PTSD symptoms can fluctuate across the lifespan, as I've explained. Um, they may decrease with age. And certainly as older people become more socially isolated, friends, family either move away or die off, or the person themselves is just making themselves more socially isolated. The other thing to think about when it comes to PTSD in the elderly is that there can be delayed onsets. So, as I mentioned earlier, trauma earlier in life, the person might have really good resilience, really good coping skills, a good social network behind them, a good work life and routine that provides support for them to cope with the distress that they've experienced. But as they're aging, they're perhaps losing some of those capacities. They become frailer physically. Maybe their cognitive capacity is not as strong as it was. Their social support dwindles, and then suddenly the vulnerability is there for them, and they start re-experiencing that event, and some PTSD symptoms can emerge. Important also to think about the trauma memories and what happens with those as we age. So we know that obviously in something like Alzheimer's disease, as one form of dementia, our memories get eroded. Certainly our capacity to recall day-to-day events becomes really difficult. Our emotional and sensory memory tend to remain quite intact. They're protected from the eroding away of our other memory centres. And so those strong emotional memories remain quite alive in us. So if there's something that happens in an aged care facility or in the person's life that triggers one of those emotional memories, those same responses are there, alive and well and very strong, but perhaps without the context around it in terms of the event and when it happened and how it happened and those sorts of things. So that can help to explain sometimes perhaps some of the unusual behavioural responses or more significant behaviours that you might see in elderly people that seems out of character or not appropriate to the situation. I might finish there and hand over to Dr. Bonwick to just talk about some of the other traumas that we see in the elderly people transitioning into aged care.
Thanks, Jane. And with that overview of trauma and its impact across the lifespan, I'm going to turn to something that's a little bit more familiar territory for our audience, beginning with a discussion concerning a future aged care resident moving from independent living into an aged care facility and then their experience through life in aged care. Perhaps you wouldn't normally consider this from a trauma perspective, but I'd like to explore this. The sad reality is that rarely do future residents welcome a move to aged care. It's usually forced upon them to some extent by failing physical health or reduced cognition, and often resulting therefore in a reduced capacity for independent life and ultimately a move into a more dependent lifestyle. The reduced independence comes with a number of traumas: decreased social connectedness, reduced self-worth, sometimes a sense of uselessness, and even guilt having failed at the basic independent tasks of life. The actual trigger to the move is frequently a significant and potentially highly traumatic health event, usually with hospitalisation, or the sad death of a long-term partner. And all of these triggers to the move to aged care are potentially highly traumatic incidents. The move itself has many traumas: giving up a home, giving up neighbours, possessions, even pets, which are so important to people's well-being, and that difficult to define sense of personal independence that can be lost, or it's certainly perceived as being lost with the move to aged care. In COVID terms, I've certainly heard from many people that there's also a palpable fear of exposure to this virus in the aged care facility. I'm based in Victoria, and that's been a major issue over the last many months. The early days adjusting to aged care life can also be quite traumatic. with the move to communal living, new routines which are not expected or known, new neighbours, and reduced privacy due to essential staff contacts. The transition in 2020 has been made even more difficult as often supportive family visits have been reduced again by the pandemic. So that transition that family visits and support can provide has been hindered. I think that's probably made all of your jobs much more hard. When considered from a resident's perspective, life in an aged care facility has many potential traumas also. Observing the decline, hospitalisation, and even deaths of co-residents can be highly traumatic. Feeling rushed by staff, but then also feeling guilty and thinking, they're very busy, I'm just being a nuisance, can create a trauma of its own. Privacy intrusions and even physical assaults by confused co-residents can be extremely challenging and quite threatening. And sadly, infrequent, but real neglect and even assault by staff can occur. But most importantly, amongst all of these traumas is really that pervasive sense of disempowerment, and I think Jane spoke to that as a common response to trauma generally. If we could have the next slide now, please. So I'm going to turn now to how multiple traumas impact on your residents. Residents are unlikely to tell you straight out, I'm stressed. Often their distress will be communicated in somewhat unexpected ways, and this is even more so when the resident's suffering with a dementia, which a high number of your residents will be. What I'm going to do is break this down into changes in emotion, behaviour and cognitions. And next slide, please, at this point. So the most common emotional change is depression as a response to traumas, and that's closely followed by anxiety. And Jane spoke about PTSD as a very specific reaction, and that usually falls within the anxiety spectrum. We've seen a lot of these responses in the general population during COVID, and also I've heard it from aged care residents with whom I've maintained contact and consultations with over this time. Also, emotional changes such as frustration, irritability and pessimism are quite common. Hallucinations and delusional thinking can also be triggered by trauma, especially in vulnerable residents, such as those suffering with either Alzheimer's disease or other forms of dementia such as a Lewy body dementia. Next slide, please. For staff, behavioural changes can be the most obvious and often the most challenging impact of trauma. This can include social withdrawal, refusal or non-cooperation with essential basic daily tasks, right through to non-compliance with necessary medical or nursing treatments, such as even taking medication. There's a spectrum from rudeness to anger through to verbal and physical aggression, which can occur and can be particularly challenging for those of you working in aged care. And residents may just become more dependent and less functional and just seem to almost just switch off in front of your eyes. Sleep reversal can also be a particular problem for night staff when staff numbers, as you all know, are rather low and any behaviours seem to be magnified. And I think I mentioned it already, but issues around anger and aggression and rudeness can often be a major problem. I'm just going to speak now a little bit about cognitive changes, and this is particularly pertinent to aged care and aged care residents. Finally, trauma may result in a sudden and unexpected decline in cognitive function, with increased confusion, being more distracted generally, reduced memory, and even reduced verbal communication. And this all particularly occurs in residents who have pre-existing cognitive impairment or dementia. And again, as I said before, this is a common issue for those who are working in aged care and the residents that they deal with. I've made a mention there also that some patients from overseas backgrounds may also reduce their communication to the point where they've reverted to using their mother tongue rather than speaking English, thus creating another challenge. I'm going to now pass back to Jane to discuss management and the concept of trauma-informed care.
Thanks, Richard. So The work that Phoenix will be doing over the coming months is really focused on building up capacity to manage these impacts within the aged care sector. And one of the key things that will be driving that is a framework around trauma-informed care. Now, trauma-informed care is a systems-based approach that can be applied at a organisational level, at a sector level, at a community level. Uh, but at its basis is the idea that if everyone is informed about trauma, understands what it is, understands its impacts, and how it can impact interactions with between people, then it provides you with opportunities to put in preventative measures, but also managing risk and incidents in a much more sustainable way and in a way that promotes health and well-being in the traumatized person. So there are a range of principles, I guess, that apply to that. The idea really is that we want to promote safety within the organisation for the residents and for staff as well. And it's important that to do that, we're understanding what a resident might feel when a resident might feel safe and unsafe. Or a staff member from that point of view. And we're also building some sense of trust in the resident that you as carers are going to be putting their needs first. So, in the context of trauma, what that involves is really being really clear about the roles, the clarity of roles, the purpose of each person's role in the organisation, and how having that dictate how they interact. Matching the information to the client's capacity is another thing. So, the idea that any engagement with an aged care member is targeted at the level of comprehension and understanding that they have, whether or not that's using interpreters, whether or not it's sitting with them, using other ways of giving information, not just through talking. And if it is talking, that it's at a pace and using a level of language that the person understands. It's finding out what might be making them feel unsafe so that you can address those directly. And following through with what you say that you will do, rather than saying, yes, you'll take care of it, but then it doesn't get followed through with. And we know that that can happen very easily just because of the resource issues that are happening and the lack of time staff members have really to get back to perhaps tasks that were intended. So important not to overpromise. Providing some choice and control is another principle of trauma-informed care. So as much as possible, providing choice. A elderly person requires showering, they're refusing, putting in a choice to that for them. We can do it now, or I can come back in half an hour and do it then. Even if it's a small choice like that, that might help to allay some of those concerns that they have, or just give them time to calm down so that they're not being showered in a state where they're highly aggressive and not feeling safe. So establish needs before offering advice and explain processes, even for those that appear significantly demented, as much as possible talking to them. At some point, they might be picking up little bits and pieces that hit home that are going to make the difference for them. A focus on strengths. So always looking for what's the individual have that I can really utilize in my interactions with them. What are the skills that they have? What are the sort of personality strengths that they have that will help me support them in a good way? And finally, it is about belief in recovery. It's being prepared to listen to those stories. It's being prepared to have patience around some of the behaviours that might arise from them. And it's about providing some empathy and understanding about what they might have been through and understanding how it's impacting on them now, and the idea that things can be different, that we can make things better for them by taking care of them. So they are all things that you will all be doing already. Trauma-informed care isn't going to be introducing anything new in terms of what you currently understand, but it certainly is about putting it in the context or in a framework that means that everybody is on the same page, working in the same way towards that common goal. And I'll leave it there and hand it back to Nicole for some panel discussion.
Thank you, Jane, and to all of our presenters. For the next 15 minutes, we're going to have a discussion with the panel around some of those issues, but also there's an opportunity for us to answer some of your questions. So just a reminder that you can ask questions into the chat function, but you can also vote on other people's questions if you think that they're of particular interest to you. Just wait for our other panel members to come in. Okay, so in those presentations, we heard all about trauma and some of the challenges that we might see in the aged care sector. And Jane's talked a little bit about trauma-informed care and some of those principles, but I thought it would be great to get a few more specific examples of how we can see trauma-informed care principles at different levels, what it means for residents, but also what it means for their families, for staff and management as well. So perhaps, Richard, you can start us off. In applying trauma-informed care for residents, what's some examples of what that might look like on a day-to-day basis?
I guess it's really important to kind of just pare it back to some basic things that are pretty easy to do and I think have a huge impact. For instance, when people are entering aged care, staff making themselves aware as they greet and meet and get to know the resident about past traumas, the sorts of issues Jane's spoken about. And I guess in our community, things like a refugee background, someone who's had war service, or someone who's had specific traumas that might be able to be identified, and then really including that in the care plan. I think it's always important when you're gathering information like that, not just to talk to the resident, but also to talk to those around them, talk to their families, those who know them better, their children, partners if they're still alive, and previous carers, formal and informal. I think also just being aware of those current traumas that I spoke about. Sometimes they're considered day-to-day issues, but for the resident, they're highly traumatic. And I think the other thing that I find is that people are often a little bit scared to raise difficult topics when they're talking to anybody. And I think just being prepared and not afraid to raise the past and present traumas that you may become aware of as a clinician or a carer, and kind of using those as a way of exploring perhaps behavioural or emotional or some of the difficulties that I spoke about.
Great, thanks, Richard. And it's one of the really important things that we see in trauma-informed care training, isn't it? Talking to people, what are their fears or concerns about having discussions around trauma and giving people some ideas around how to contain those discussions and how you might protect yourself as well. Jane, wondering if you could now comment on what trauma-informed care principles might look like when we're working with the families of residents.
So I think, as Richard says, it often is just about bringing the family into those conversations, really, and making sure that they're informed. I mean, for many people, I know, working a lot with war veterans, particularly from earlier wars like the Second World War, First World War, they were reluctant to talk about their experiences. And so family members might be quite ignorant sometimes about some of the experiences they've had. So I think important for families to be informed also about the impact of trauma and the way that you are working as an organisation to support people who might have had trauma in the past. Bringing them in as part of the care planning, discussing with them, getting their opinions about what's going to be the best way to support this person when things do go awry for them, when stress does happen, what's worked for them in the past in helping them manage that, and allowing them be part of that patient management team, whilst at the same time informing them and skilling them and educating them about trauma-informed care.
And I really like that idea around that discussion around, what are the things that the person may have been using to cope with different things in their life, and having those discussions around, well, how can you incorporate them into their new routines and their new living situation as they move into aged care. So, Anne-Laure, what then might this look like for staff and managers in terms of applying trauma-informed care? Does it mean we have to change lots of policies and put lots of extra work and procedures onto staff?
No, not at all. That's not the idea. I think for trauma-informed care, it's about adjusting existing processes. So what Richard just described. So if you're thinking about the usual process you have for introducing someone to aged care, and they're coming into the facility and you're planning for their care, thinking through, okay, if 75% of the population will have experienced some form of trauma, how do we make sure that if the person is ready, we're not suggesting, by the way, that you ask everyone about their trauma background necessarily, but that it's also at least part of your conversation, and that you have a question there. And if the person or their family are aware and are ready to talk about it, at least a conversation can be had, and that you're aware of it so you can make a care plan. So it might be a small adjustment in the process you have in place. And also, it doesn't mean changing a worker's role. This is not about becoming a counselor or a trauma counselor. It's really about thinking, okay, within my role, how do I take a trauma lens? How do I think about that person's behaviors, their moods, their needs, and how do I think about my role? So it may be, for example, and I think, Richard, you mentioned it, if you have someone that has experienced sexual assault in the past, and you're kind of aware of that, or you suspect that might be the case, that you just ask permission before you touch them. Something as simple as that you don't just automatically touch them. So it's a very small thing, but it's a really big thing for that person. And it's making sure that the organization supports that person. And I know we've got a few questions about vicarious trauma. I think the really important thing for staff is that they're really supported in being skilled to make those small changes, though, and that their well-being is protected. Jane mentioned one of the big principles of trauma-informed care is that we keep the residents feeling safe, but also the staff that witness aggression or that witness someone being distressed continuously and not being able to change that. And that can have a huge impact on staff. And the facilities need to have, or services need to have, something in place to protect the staff and help them deal with that.
Yeah. So given all of that, in aged care settings, who's responsible for putting in place trauma-informed care practices? Jane, who would you see as being responsible?
Well, I think absolutely every single staff member is responsible. There are obviously different levels of responsibility, and management need to obviously lead the implementation of a trauma-informed care model within the workplace, and that often will might involve some change to policy, but it's more likely to involve some training in the first instance in terms of making sure all staff are informed about trauma and its impacts, but also the trauma-informed care approach and model and how they're going to do that within the organisation. And also spelling out, I think, the principles of how it's going to be applied in that organisation. But every staff member then has a responsibility for educating themselves, for attending that training, for following through on those guidelines and policies and processes that management are putting in place. I think the other really important thing in terms of everyone's responsibility is to be aware of their own emotional responses to either their own traumas, but also on hearing other residents' trauma and in reacting to residents who might be distressed and behaviourally disturbed, because that is going to have an impact as well on how they interact. And if we're not dealing well with that, then that's going to escalate the distress and the behavioural concerns of the residents. So I think there are, the answer to me is that everyone, there will be different responsibilities that each one will have.
Hey, it's interesting that point you're bringing up about self-care. Really, it's a self-awareness, but also having self-care in place. It actually links nicely into some questions that we're seeing come through on the chat. Thank you to people who are putting in questions. Helen's wondering around the concept of vicarious trauma, which you've just touched on, Jane. Maybe if Richard, you could talk to us a little bit about what vicarious trauma is and how it can impact upon staff.
I guess just thinking back to what I was saying about the traumas of residents, and I think there's amazing traumas, or not amazing is not the right word. I mean, severe traumas for staff working in aged care as well. Just thinking about what happens day to day in an aged care facility. You do sadly see a lot of pain and suffering, and that has a wear and tear on staff. It impacts on them as well. And I guess it comes to the point that Jane was speaking about. And I think it's something we're going to address in later webinars, Nicole, as well. Really looking at trauma and staff and how we ameliorate those sort of vicarious traumatic issues that arise in the aged care services for staff working there day to day. Sometimes we just normalise these things, but it's good to take a step back and think about what we go through every day at work. And caring for older people, the physical involvement with them, sadly at times the aggression, the difficulties, can have a huge impact on staff. So I think it's an area, it's good it's been raised, and I think as a team we're well aware of it and hope to address it further in later webinars. So I get that's a bit of free advertising, isn't it, for
yes,
our later webinars? Hope that
great work there, Richard.
come back and join us. For
can I just throw in there, because it probably relates back to that other question about responsibility. I think what goes along with instituting a good trauma-informed care framework and policy within the workforce is having a good process for dealing with trauma in the staff group. So when critical incidents do happen, injuries happen, psychological trauma occurs, then there's good supports within the organisation to manage that.
And that's a great point, because we talked right at the beginning of this about the different types of trauma, that they can be things that you experience directly, but they can also be indirect. They can be the vicarious, they can be the one-off, but they can be the cumulative. And you have to be thinking about in those policies and procedures how you would deal with and mediate and moderate the risks of all those different types of exposures, not just in residents and their family members, but also in staff at all levels. I think that it fits in nicely with a question that we've had from Nathan about what level of detail do you need to understand the resident's experience of trauma to manage their reactions or their triggers? Anne-Laure, would you like to respond to that? And
Sure.
In terms of what's the best approach to having these types of conversations?
Yeah, sure. Well, I think to begin with, not everyone is ready to talk about trauma, and not everyone is ready to talk in depth about trauma. So you have to look after the person you're caring for, and you have to look after yourself. And those two considerations are really important when you make a decision about how much you're going to ask about trauma. And for me, you may have people where you say, "Oh, you seem a bit sad, how are you going?" And they'll go and tell you, and you're not ready. And it's about containing the amount of detail you get, because in your job, it's not your job to hear the whole story. If you can, and you feel you're able to, and you've got good support, you can, if you like, but it's not your job. That belongs with someone like a counselor. But what is enough is knowing that they have experienced something. So it might be just enough to know that, I know they're veterans, and I know they were prisoner of war, or I know they're from a refugee background, and that it was really tough getting to Australia, actually. So it's knowing that much detail. That's really what you need to know. And also understanding then what some of their triggers might be. So people can tell you, I don't like the sound of the shower because it reminds me of when my dad was about to hurt me, or sometimes they just say, I don't like that. And it's saying, okay, maybe that's a trigger and I just need to find a different way of providing care or find a way to help them calm down. So you don't need to go into the detail of the traumatic event. And sometimes you will suspect, but you might not know. And then I would just treat those reactions as maybe it's a distress. It's not that they're being difficult. So what can I help them? How can I help them feel in control and safe so that they're less aggressive towards me or less distressed?
Yeah. And then there was a question that's come in from Michelle of, that sometimes you won't actually know much about, you work in communities where you don't know much about their background. You might not be spending a lot of time with them. How can we still work within the principles of trauma-informed care if perhaps we don't know much about those details? And maybe Jane, you could comment on that.
So yeah, look, I think what a trauma-informed care framework does is say I'm always going to approach the resident or the person I'm working with a trauma-informed lens, which means I'm always going to have a question about whether or not trauma might be part of this person's presentation. And if there's something unusual in their presentation or there's something that I'm not quite getting, if I think about that from a trauma perspective, does that help to explain it? And does that then change how I might manage this client, how I might manage them, what I might do with them? So I don't think I don't think you have to be fully informed about the people that you're working with. It's more that you're going in with this very open mind and empathy and willingness to provide that safety and trust in your interactions with them, which is important.
Yeah. Sorry, Anne-Laure, did you want to say something?
A lot of trauma-informed care principles are really about this respectful relationship that you form with people, where you give them as much safety and control in your interaction with them. And that's really essentially it. So it's knowing how to do that really helps.
Yeah. And it looks like there's a question about, where you provide this trauma-informed care, which part of the organisation or staff or the networks of people that support people in residential care, who should be getting trauma-informed care? And Laura, can you comment on that?
So I think it's important that anyone across the staff knows about trauma-informed care and has enough knowledge at least to understand that people might be triggered and that people's behavior might be explained by their experiences of trauma. So you might be a kitchen staff and you have someone that's being triggered by a traumatic memory. It might help you and to understand where that person might be coming from. Might not be expected to do anything about it, but it might help you feel better about what you're seeing. And it might help you think, next time when I see that person, I'll do things slightly differently. So it could be anyone I think anyone would benefit from learning about trauma-informed care.
And I think that actually answers a question we've had about how casual or agency staff deal with clients that they don't know, that this is the type of training that can assist with those types of interactions as well. We only have a couple of minutes left. Richard, you've spent a lot of time working in aged care facilities. In terms of, we think about, we've got, I know, several senior people from facilities, CEOs, clinical care staff who are online at this webinar. How can applying the principles of trauma-informed care, what's the benefit for them and their organisation and their staff?
I have the pleasure of working at a very large private psychiatric facility and dealing with management on a day-by-day basis. And there's always that different view of the world that managers take of what's kind of, it all sounds wonderful and staff, it's great they do it, but why? Why do we do it? And I think there's many, many reasons why. I think I've always had sort of a truism, good clinical care is good economics. And I think expanding and using the principles of trauma-informed care fit that beautifully. There'll undoubtedly be an improvement in the quality of care to the residents. Families will be happier, and I'm sure that managers out there deal with families all the time, and I think happy families must make a good facility. It must make life a lot easier when families are happy with what the service that's being provided. I think staff are more engaged. I mean, we've seen a number of really good questions that have come up from staff. How can I do this? I mean, there's an interest, isn't there, in understanding these issues. And so training staff, supporting staff, peer support amongst staff all helps with better engaged staff and therefore better quality of care. But I come back to the point, to managers, it is good economics. Things will work more smoothly. There'll be less behavioural problems with residents. Staff will be better engaged, and I think your whole facilities will just run more smoothly, and that's what managers want at the end of the day.
Great,
so
thank you.
I'm going to put a managerial hat on there, Nicole, but
yeah, no, that was great.
It was very much directed at those with that hat on in the audience.
And trauma-informed care helps staff well-being and staff turnover. I think that's really, for staff, it really does have an impact on staff well-being, which is a really important thing.
Yep. Look, we have come to the end of our time, which is available for this webinar discussion. Thank you to our panel members who we will now. I thank you for those people who've been asking questions too. We don't have time to answer any more questions, but we will be having more webinars where we will be able to hopefully look at some of these things in more detail. The last thing that we're going to do is we're going to launch a poll, which you can access in the Q&A section below the video stream. We'd really appreciate you completing this. It's only 4 questions, and it really helps us to improve our services in the future webinars. While you're completing the poll, thank you for taking the time out today to attend and learn about the impacts of trauma in aged care. I know that people are busy. I really hope that you found it informative and helpful. Thank you so much to Jane and Laura and Richard for sharing your expertise with us. As we've said, we have more webinars which are planned. The next one will be early in the new year, and we'll be discussing in greater detail the impacts of dementia and what it means for providing trauma-informed care. But if there's also other topics that you're really interested in knowing about, add in a comment in the chat, or else over the next few days we'll be sending out an email to a link of the recording of this webinar. I know several of you have been asking about that, so that this webinar will be available as a recording, and we'll also give you more information on where you'll be able to access a range of resources and training as they're being developed over the coming months, and also will provide you a point of contact if you have any other suggestions about the webinar, or if you have any particular follow-on questions. Thank you again so much for your time today, and you hope that you'll stay in contact with us and join us for future events.